Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. In this episode, we will be hearing pharmacist perspectives on the latest data on HIV care and prevention from CROI 2024. I'm joined by Dr. Samantha Strong, Clinical Director of Pharmacy at Nevada Health Centers in Las Vegas, Nevada, and Dr. Nimish Patel, Professor of Clinical Pharmacy at University of California, San Diego in La Jolla, California. For more information about this program and to follow along with the slides, and also to register for one of our live sessions in this series, please visit the links in the show notes for this episode. To get access to all of our new podcast episodes, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Now let's get started.
I have the privilege of discussing today some of the exciting new data that was presented at CROI earlier this month. And specifically, I will be discussing the new data on current long-acting antiretroviral therapies. To start, the first study is the CARES trial, which studied long-acting cabotegravir plus rilpivirine in sub-Saharan Africa using a public health approach. This study is important because although long-acting cabotegravir plus rilpivirine is a recommended option for HIV treatment in resource-rich settings, additional evidence was needed to determine the effectiveness of this option in a population with different demographic factors, different viral subtypes, and varying prevalence of drug resistance. The CARES trial is an ongoing 96-week randomized open-label study being conducted in 3 African countries, Uganda, Kenya, and South Africa. And the purpose is to assess non-inferiority of switching virologically suppressed adults to long-acting CAB plus rilpivirine every 8 weeks versus continuing with oral standard of care. Adults that were receiving standard oral ART with a viral load less than 50 copies, with no history of treatment failure and no hepatitis B infection were randomized into 2 groups. One group received 4 weeks oral CAB plus rilpivirine and then switched to the long-acting injectable form, while the other group stayed on their oral standard of care ART. The primary endpoint was the proportion of patients suppressed with a viral load less than 50 copies at week 48. And then there were multiple secondary endpoints, such as confirmed virologic failure, safety, and tolerability. And then consistent with this public health approach, viral load monitoring was less frequent in this setting. It was done at week 4 and then every 6 months, and then no resistance testing was completed at enrollment. Now, if we look at the baseline characteristics, patients were middle-aged with over 50% being women, and 21% of patients had a BMI greater than or equal to 30. And this is notable because previous studies had identified high BMIs as a potential predictor of virologic failure. And then the average time patients had been on ART was about 8 years, with most participants having prior exposure to NNRTIs and were currently on an integrase inhibitor. Particularly interesting is that participants were enrolled in this study without prior resistance testing. And this is because resistance testing is not readily available in this setting. Now, what they did was they completed proviral testing retrospectively on dried blood samples, which is what leads to the interesting results we'll discuss in a minute. The data presented here is from that archived proviral DNA analysis, with over 50% of participants having an HIV subtype A1, which is the most common subtype in sub-Saharan Africa. And then there was a substantial amount of rilpivirine and cabotegravir resistance mutations and intermediate and high-level resistance at baseline. Okay, so then the primary outcomes showed similar results between both groups as far as maintenance of virologic suppression, with 97% in both groups. This demonstrated that long-acting CAB plus rilpivirine is non-inferior to oral standard of care, despite the presence of archived resistance. About 83% of participants received all injections on time. There was one confirmed virologic failure in the long-acting CAB plus rilpivirine group. This patient received all injections on time and had no resistance at baseline. However, they did develop high-level resistance to rilpivirine and intermediate resistance to CAB at the time of failure. And this participant was able to be resuppressed on dolutegravir TDF3TC. So then now looking at the safety, tolerability, and treatment satisfaction data, were very few discontinuations due to adverse events and only one discontinuation due to injection site reaction. The majority of adverse events were grade 1 and grade 2. And then regarding patient satisfaction. So at baseline, we had 54% and 52% of participants reported satisfaction with their treatment in the long-acting and standard of care group. However, by week 48, there was a statistically greater increase in the reported satisfaction in the long-acting group. So patient satisfaction rose by 28% in the long-acting group versus only 18% in the standard of care arm. Okay, so then the next study I want to talk about is IMPAACT 2017, also known as MOCHA. And this trial studied switching to long-acting CAB plus rilpivirine in adolescents living with HIV. And this is great because this is an important demographic that we need more data on. And so the MOCHA trial was the first trial to treat adolescents with long-acting CAB plus rilpivirine. And this was an open-label, non-comparative phase 1, phase 2 study. Evidence from cohort 1 was used to inform the approval of long-acting CAB plus rilpivirine in adolescents. Now, this new data here focuses on cohort 2, which enrolled 144 participants from 5 countries. Participants were between the ages of 12 and 18 living with HIV who were virologically suppressed and weighed over 35 kilograms. They were all switched from their oral regimen to oral CAB plus rilpivirine for 4 weeks and then switched to the long-acting injectable form, and that was administered every 8 weeks. The primary outcome was safety through 24 weeks, and then the secondary outcomes included viral load, number of virologic failures, and adverse events through week 48. For baseline characteristics, we have a median age of 15 years, half were female with 74% Black participants, and the majority of participants acquired HIV via vertical transmission. Virologic suppression was maintained in 97% of participants at week 24, so almost identical to what we observed in the CARES trial. And then PK analysis demonstrated comparable CAB and rilpivirine troughs that were observed in previous studies in adults. And then regarding safety, as expected, injection site reaction was the most common adverse event, most of which resolved within 7 days. And then there were no discontinuations due to adverse events. And then there was one participant who became pregnant, which resulted in a live term birth. And then the next study we'll go over is the LATITUDE trial. This was a randomized open label phase 3 trial with participants with HIV with a history of poor viral response to oral therapy due to challenges with treatment adherence. These patients could not have hepatitis B or known integrase or rilpivirine resistance. This was a unique study that used economic incentives to help increase medication adherence to oral ART. And that was in order to get participants virally suppressed to be eligible for randomization into the trial. At the start of the trial, participants were required to be undetectable for 24 weeks before moving on to step 2. At step 2, that's where they were either switched to long-acting CAB plus rilpivirine administered every 4 weeks, or they were continued on their oral ART. This protocol was later modified over time to allow randomization after only 4 weeks of viral suppression. The primary endpoint was a composite endpoint of treatment regimen failure, defined as the earliest confirmed virologic failure, or discontinuation during step 2. And then the key secondary endpoints included virologic failure, treatment-related failure, and permanent treatment discontinuation. So then for baseline characteristics, the study made a concerted effort to recruit diverse participants in respect to age, gender, and race. There were 14% of participants that reported current or previous injection drug use, and the median time since HIV diagnosis was 13 years. And then what's noted here shows that even though patients needed to be suppressed at screening, there were still 17% of participants in the long-acting group and 7% in the standard of care group that were viremic by the time they actually entered step 2 of the study. And that was due to the window period between screening and then enrollment. And then, as expected, injection site reaction was the most common adverse event, and 93% of participants in this study received their injections on time. So, reviewing the outcomes, with regards to the primary outcome, 24% of participants of the injectable arm compared to 39% in the standard of care arm had a regimen failure. The difference between the groups was almost 15%, but did not quite reach statistical significance. However, the secondary outcomes of virologic failure and treatment-related failure did meet statistical significance in favor of the long-acting arm. So demonstrating 7% versus 25% virologic failure in the long-acting group versus the standard of care group, and then 10% versus 26% of treatment-related failure in the long-acting group versus the standard of care group. And then there was no statistical difference between groups regarding permanent treatment discontinuation. So this difference in the secondary endpoint led the Data and Safety Monitoring Board to recommend stopping the study early due to the superior efficacy of long-acting CAB plus rilpivirine over oral standard of care in this difficult to treat population. So after 52 weeks, further enrollment and randomization of the study were stopped, and all eligible participants were offered the option to switch to long-acting CAB plus rilpivirine, and monitoring was continued. All right, and then next, there was additional follow-up data presented on San Francisco's Ward 86 retrospective cohort study of people living with HIV without viral suppression who were started on long-acting CAB plus rilpivirine. These participants could not have CAB or rilpivirine resistance at baseline. There are currently 286 patients at this clinic on injectable therapy, with 59 of those patients having a history of viremia for more than a year. For this study, all unsuppressed participants received long-acting CAB plus rilpivirine administered every 4 weeks, and only if they achieve viral suppression for 3 to 6 months are they given the option to go to every 8 weeks. And the primary outcome is viral suppression and long-acting CAB plus rilpivirine persistence. Some notable baseline characteristics in this study include over half of the individuals had unstable housing or were unhoused. 61% reported current meth and or cocaine use. There was a large range of CD4 counts in viremia, with almost 70% of individuals having a viral load over 10,000 copies. These baseline characteristics really mirror our most difficult to treat population, and that's why this cohort study is so fascinating. And so that brings us to the results. At week 48, 81% of the patients remained on long-acting CAB plus rilpivirine and maintained virologic suppression. There were 5 participants who discontinued long-acting ART and restarted oral ART. And then there were 2 failures with resistance in individuals who received on-time injection. Based on this data, the IAS USA updated their recommendations for long-acting CAB plus rilpivirine on March 1st of this year. It now states that when supported by intensive follow-up and case management services, and these are the services that the San Francisco Ward 86 are able to provide to their patients. So when supported with these intensive follow-up and case management services, injectable long-acting CAB plus rilpivirine may be considered for people with viremia who meet certain criteria when no other treatment options are effective. And so these criteria include the patient's inability to take oral ART despite extensive effort in clinic support, the patient having high risk of HIV disease progression, and then also ensuring that the virus is susceptible to both cabotegravir and rilpivirine. And when applicable, patients should be referred to treatment of substance use disorder and or mental illness. And then lastly, we have a case series on the off-label use of long-acting CAB with or without rilpivirine plus long-acting injectable lenacapavir. Currently, long-acting CAB plus rilpivirine is the only recommended complete long-acting ART regimen. However, it is not recommended by the World Health Organization in low and middle income countries, and that's partly due to the higher rates of NNRTI resistance, which limits the utility of rilpivirine. There are 4 US clinics using long-acting CAB plus lenacapavir off-label in select patients due to adherence challenges. And the most common reason for needing to add lenacapavir was because of NNRTI mutations. At baseline, only 47% of patients were virologically suppressed, and after starting lenacapavir, that number increased to 94%. One barrier to this off-label administration is that long-acting CAB alone is only approved for those without HIV using it for PrEP. So you may have difficulties getting that approved by insurance. So I know in some cases in this trial, they are prescribing long-acting cabotegravir plus rilpivirine and then prescribing the long-acting lenacapavir, but they might not be administering the rilpivirine if the patient has the mutation and it's not really effective. So although this is just a case study, it's very promising data, and it suggests a strong need for trials to study the combination of long-acting CAB plus lenacapavir so that patients that do have NNRTI resistance have a long-acting complete ART regimen that's available to them. So some key take-home points include that in the CARE study in Africa, long-acting CAB plus rilpivirine was non-inferior to standard of care oral ART using a public health approach. Data from the MOCHA study supports safety and efficacy of switching to long-acting CAB plus rilpivirine among adolescents living with HIV. In the LATITUDE study, in people living with HIV with adherence challenges, long-acting CAB plus rilpivirine was superior to standard of care oral ART. And then in people living with HIV who were viremic at initiation, long-acting CAB plus rilpivirine was effective through week 48, and that was from the San Francisco Ward 86 study. And then in select people living with HIV unable to take oral ART and unable to use long-acting CAB plus rilpivirine alone, long-acting CAB plus lenacapavir actually doubled viral suppression. All right, so this brings us to our patient case. We have a 53-year-old female who has been living with HIV since 2009. Her treatment history includes experience with our first generation integrase inhibitors and efavirenz, so she does have NNRTI exposure, and she's currently taking bictegravir FTC TAF. She tells us that she forgets to take her medication a few times per week. However, she has not missed any lab or clinic appointments in the past year. She currently has a viral load of 876 copies, and her CD4 count is 997. So I am going to have Dr. Patel join me as we go over some of these discussion questions. So I'll have you start, Dr. Patel. Would you consider long-acting cabotegravir plus rilpivirine for this patient?
That's a good question. I think certainly I'd want to know the resistance status, the patient's virus. And, I guess based on the CARES data, even in the presence of some underlying resistance, it seemed like the regimen was still effective. So even if I couldn't get that right away, I think I would certainly consider cabrylpivirine for the patient. I think with some adherence challenges, I think some of the things that are being done at Ward 86 would be helpful to ensure that the patient stays on the regimen.
Yes, I agree. Other information I would want to get for this patient is her hepatitis B status, just because we want to remember that long-acting CAB plus rilpivirine does not cover for hepatitis B. So making sure we have that, out of the way before doing any switching. And as you mentioned, we're gathering a good amount of data that's saying that maybe even if a patient is not undetectable, that it might still be good to start a patient on long acting if med adherence is an issue. And then in what scenarios would you consider using long acting CAB plus lenacapavir?
I think NNRTI resistance is fairly common. And for those patients who have NNRTI resistance and want a long acting regimen, I think using long acting cabotegravir and lenacapavir is a really attractive option. So, yeah, I think just in patients who have underlying NNRTI resistance, that would be one quick choice that I would think of.
Yes, I agree. And then I think that brings us to our next section.
I'm going to switch gears a bit and talk about the impact of doxypep on rates of chlamydia, syphilis, and gonorrhea in San Francisco. And San Francisco was a fairly early adopter of doxypep. And in October of 2022, the San Francisco Department of Public Health released guidelines for doxypep use, which included recommending doxypep to cis men and trans women if in the past year they had a bacterial STI and reported condomless anal or oral sex with at least one cis man or trans woman. And the guidelines also included offering doxypep to cis men and transgender women with multiple partners without an STI in the preceding year. So there were 3 clinics in San Francisco that quickly adopted these doxypep guidelines, and cases of chlamydia, gonorrhea, and early syphilis among men who have sex with men and trans women from citywide surveillance data were evaluated in the study. And over the next couple of slides, we'll talk about the rates of each of those STIs and how they changed pre and post implementation of doxypep guidelines in San Francisco. Prior to the doxypep guidelines, the rates of chlamydia are fairly stable, and the predicted trend was expected to be also the same. But what was observed in the post period was a significant decline in chlamydia cases, roughly 6.6% per month. And then when we look at early syphilis, we see a similar finding. The pre-period trend, the rates are fairly stable. And under the null hypothesis, the predicted trend would be the same. But what was observed was pretty significant decline in early syphilis rates in the post period at roughly 2.7% per month. And then in terms of gonococcal cases, this was a bit of an interesting finding because when you look at the pre-period trend, it's already on a decline. So under the null hypothesis, the predicted trend would be to continue to decline. But what was actually observed was a subtle increase in gonorrhea cases in the post period. So roughly 1.8% per month increase in cases in the post period. So implementation of doxypep was associated with significant declines in chlamydia and early syphilis cases, but not gonorrhea among men who have sex with men and transgender women in San Francisco. There's certainly more data that are needed to understand what's happening with gonorrhea and continuing monitoring in terms of disparities in uptake by different racial and ethnic groups and tetracycline resistance patterns in gonorrhea and the impact on how that affects the effectiveness of doxypep over time. So I'm going to ask my co-presenter to help me out with the discussion here. And so Dr. Strong, for which people are you recommending doxypep? And would you consider recommending doxypep for a cisgender woman?
Yes, so I'm recommending doxypep to my cisgendered men and transgendered women if they've had a bacterial STI in the past year, or if they report condomless sex with multiple partners. I have not to this date prescribed DoxyPEP to a cisgendered woman, even though there is limited data on there. Theoretically, there should be no difference. I just haven't had that opportunity yet. How about you, Dr. Patel?
Yeah, I mean, I've only done it in one person who's asked for it. And we learned a lot of lessons with the rollout of oral PrEP. And yes, the studies were initially done in men who have sex with men and trans women. But I think one of the things that we learned from the PrEP rollout was that the uptake among women, once those studies were available, was fairly low. And I fear that we may be doing the same thing and repeating that pattern with DoxyPEP. So I feel comfortable recommending DoxyPEP for cisgender women. But, as more data emerge, I think it'll be a stronger and more compelling case. And I'm going to just wrap up with some data on post-exposure prophylaxis in a study from Daniel Tan's group in Toronto. This was evaluating bictegravir FTC-TAF as PEP in Canada. So individuals were started on a standard PEP regimen, and within the first week, they were switched over to a single tablet regimen of bictegravir FTC-TAF, and then further randomized to text message check-ins or no text messaging. And what was observed is that 88% of individuals were able to complete 28 days of PEP. No seroconversions were observed, and it was a well-tolerated regimen. And then in London, a study was done looking at PEP to PrEP in men who have sex with men who are offered a quick start opt-out PrEP option. So they're given a 1-month supply of FTC TDF for PrEP to start immediately after their PEP regimen. The study involved 282 men who have sex with men and 6 transgender women. Under half of them had previous PrEP use, but after the PEP regimen ended, 3/4 of individuals started PrEP, and then half subsequently had attended a PrEP visit. So a nice opportunity to transition people from PEP to PrEP.
Thank you very much to our faculty, and thank you to our listeners for joining in. As a reminder, to view the full program, Contemporary HIV Treatment and Prevention 2024, on the Clinical Care Options website, click on the links in the show notes for this episode. To access all of our new podcast episodes, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.